I'm not an expert, and that I wanted to prepare this presentation because you know that when you prepare a presentation, you end up knowing a lot more than you thought about a single topic. So I wanted to do this because I had the impression that we were quoting central sensitization too often and in the wrong setting, and I wanted to know more about that. I also wanted to take the time to find the difference between sensitization with S and a Z, which is irrelevant, but I can give it to you if you want it. And also I wanted one of our clinical fellows to sleep at night because he kept asking me, what is central sensitization? And I couldn't really tell him back. So I hope that he's gonna sleep better, which is a very good thing because it will prevent central sensitization in his future and also have a bit of quiet in my life. Objectives. I hope that by the end of the presentation, you will understand the pathophysiology of central sensitization. You will learn how to explain this phenomenon to patients. You will learn how to integrate the diagnosis into our routine clinical practice. And I guess that by doing this, I'm gonna be maybe disappointing our colleagues from the research center because this presentation might be on the clinical side. However, I'm gonna torture you guys with some basic biological changes that you need to hear. That I have to disclose the fact that I'm mostly a clinician, and although I did basics research, that time is far in my past. And I hope that I will help you to identify the best therapeutic recommendations to treat central sensitization. So the outline of the presentation is that I will present the definition between peripheral and central sensitization, some molecular changes, and some anatomical changes happening in subjects presenting with central sensitization. I will go over the clinical manifestations and the tools to identify that, and possibly to talk about the therapeutic tools that can be offered to assess and also to treat these patients. So start with first the definition. Central sensitization, not central, sensitization refers to reduced threshold and augmented response of the sensory nerves in the peripheral to external stimulus. So this is the first example of how to explain sensitization to patients. When you enter a room that is very dark, you don't see anything. But a few seconds later, your neurons, they are gonna adapt to the light, they're gonna become sensitized, and then they're gonna see maybe silhouettes. This is a natural response to darkness. And the contrary happens, and for the anesthesiologist in the room, the contrary happens when, for example, you're doing anesthesia for a laparoscopy, and then suddenly you feel a bit cheeky, and then you just switch on the lights without any warning, and then the surgeon, and this has happened to me, I still remember the shout that he gave, when we switch on the light too fast. This sensitivity to light after being in the dark for a while, this is called sensitization. And this is something that our patients, I believe that they will understand very well. Peripheral sensitization obviously happens in the periphery. We call it this inflammatory soup. We call it many different ways, but we all know that around the tissue damage, there is release of pro-inflammatory substances that potentially they might increase depolarization. They might facilitate and increase facilitate depolarization, and they might cause excitation. And that is the basis for some treatments that eventually they are applied in the periphery. I don't think that I need to go over that because we all know what type of therapies they can be potentially given at the periphery and not central. This peripheral sensitization transduces into two phenomena, allodynia and hyperlogisia. On the left side of the screen, you can see an electrophysiological recording of a rat, of the hind paw of a rat. And you can see in the top how increasing the temperature in a normal, in a unharmed controlled rat, it causes some spikes of nerve conduction. And this transduces the normal pain sensation that a rat under anesthesia will experience when causing when causing a noxious stimuli. However, if this is the neuron of a rat who underwent a peripheral nerve injury, for example, a spinal ligation or a partial sciatic ligation, these neurons, when subjected to an increase of temperature that is noxious, they respond much more. So we can say that this is something called hyperlogisia, which is exaggerated pain in front of something that should not be that painful. I believe that patients, they will understand well what's allodynia and hyperlogisia if we use examples that we all understand. When you fall asleep in the sun and you wake up with a sunburn, anybody touching your shoulder will get a response of an aversive response. Pain in front of touching a stimuli is called allodynia. When you have an ingrown toenail, or when you have a blister after using new shoes, that pain is a continuous pain. However, when someone by mistake, by accident, steps on your toe, or maybe just hits you in the back of your heel, that will be a tremendous and exaggerated pain. That is called hyperalgesia. And allodynia and hyperalgesia, they are mechanisms that traditionally they have been related to central mechanisms, but actually it's not true. Actually, you can see mechanical allodynia and hyperalgesia in patients with peripheral sensitization. And in fact, these are phenomena that they are really needed for us to heal. The more protective we are by exaggerating our responses, the faster we're going to heal. Therefore, to a certain extent, this is the type of pain that we say that it's a good pain. And with that, I will start talking about central sensitization. And just to make it clear, central sensitization are the changes happening from the first synapses up to the brain, up and down. So how can we explain central sensitization? Imagine that you're with your friends and your family watching a movie, and everybody's fine. The movie is very funny. You're having a good time, and suddenly the doorbell rings, and the pizza is here. So somebody will get up and get it. But what if the movie is, let's say, The Exorcist? What if you are in high tension? What if all is quiet except for the movie, and suddenly the pizza is here, and with the doorbell, you jump. Why do you jump? Because you are sensitized. And you're sensitized not because something in the periphery, actually is the brain. The brain and the situation of the horror movie put you in a situation of hyper-awareness that make you react wrongly and in an exaggerated fashion to a noise. You are centrally sensitized. It might sound a bit stupid, forgive me for this, but I think that it's important that patients, they understand that central sensitization is also the result of changes of our higher neural structures like the brain. If you want to know more about central sensitization, I'm presenting here three papers that they are, I would say, seminal papers in order to understand better. Clifford Wolf has been probably one of the best researchers who has studied about central sensitization. There was a recent paper in Lancet Rheumatology that is very clinically oriented. And there is also a presentation, a paper by Rohini Kunar, who happened to be one of our speakers at one of our Pain Frontiers. And the paper is, it goes really deep into the anatomical and physiological and biochemical changes happening in patients with chronic pain, and which and going over central sensitization. The images are really, I would say that for a basic researcher would be like reading a Playboy magazine, because the images are amazing, and you can understand everything there that it's depicted. In order to present some of the definitions, we know that central sensitization is an amplification of a neural signaling within the central nervous system, and that elicits pain hypersensitivity. In both, because hypersensitivity is probably one of the key features of central sensitization. There is also an increased sensitivity outside the primary area of tissue injury or damage, or beyond the innervation territory or lesion or diseased nervous structure. That is also a hallmark of central sensitization. So the second key is that the pain extends beyond the anatomical boundaries of the tissue injury. Naciplastic pain now is a third mechanism accepted by ISP in order to explain the type of pains that our patients they have. It was nociceptic and neuropathic. Now we have a third one, and it's as a key feature, there is an altered nociception with sensitization as the major underlying mechanism. In general, there are morphological, biochemical, and electrophysiological changes affecting the nociceptive pathway, including from the periphery to the brain, up and down, all to cause that the brake doesn't work very well. So there is an impaired descending inhibition, and also that the accelerator of the pathway, it works too well. And there is an enhanced descending facilitation. So I'm going to present few changes that have been demonstrated in animal models. Dr. Clifford Wolf presented this very well known graph or picture of pain and touch versus hyperlogisia and allodynia in central sensitization states. And Dr. Wolf was drinking from the knowledge from Melsack and Walk, because most of these drawings, they are based on the particular interaction between different types of neurons at the level of the spinal cord. So in normal sensations, touch might potentially touch fibers might inhibit pain, but in peripheral, in persistent central pain states, this inhibition is not working well. So what we all know by the gate control theory, for example, but also there are other changes that I'm going to be explaining a bit. At the level of the periphery of the first synapses, it is known that there is a long-term potentiation of excitatory sensory synapses. So those synapses that they are supposed to bring the pain up to the brain, they are working too hard and too well. This potentiation has been also named as wind up, which is a pure physiological phenomenon, which is hard to link with clinical features. However, what it is known is that when a neuron shows long-term potentiation after, for example, being sensitized by injection of capsaicin, there is an increase in the presence of certain receptors like NMDA receptors, and this increase in presence of these receptors, as you can see at the bottom right, if when blocked with an NMDA receptor antagonist, like for example ketamine, it can reverse this wind-up phenomenon. Also, at the first synapses, there are some changes caused by persistent pain. There is an increase in the probability of presynaptic neurotransmitter release. There is an increased activity. Therefore, there are more vesicles being released. And also these vesicles, they target more active zones. Therefore, there are more neurotransmitters and more areas where these neurotransmitters eventually they are going to be released into the first synapses. This is related with the teaching from Clifford Wolf, where it is suggested that there is a pathological sprouting of tactile fibers that instead of synapsing with deeper layers of the dorsal horn, where deeper layers are mostly tactile regions, instead of that, they sprout into superficial layers. So a neuron that is supposed to bring the sensation of touch to the brain also connects with a pain neuron at the superficial aspects of the spinal horn. Therefore, a sensation that should be touched turns into a sensation which is pain. This is what we call allodynia, of course, at least tactile allodynia. Also, we know that in the spinal cord, at the dorsal horn of the spinal cord, there are interneurons that they act as they have an inhibitory function. In the presence of persistent pain, these neurons, there is a loss of inhibition of these neurons because these neurons are working less effectively. At the level of the brain, there are also some changes. Probably the best changes that they have been studied are the reorganization after certain peripheral injuries, like, for example, amputation of CRPS, where the primary motor cortex and the somatosensory cortex, they are altered after peripheral injury. But there are many other changes happening in the brain that might account for the presence of central sensitization. There are expansion and shift of cortical representation, as I mentioned. There are alterations in gray matter volume. This is particularly interesting following a research that was done at our research center, where it was demonstrated that patients with chronic low back pain, they had a decreased volume of gray matter. And this, interestingly, patients responding to blocks were the ones who could revert this alteration in volume. There is an altered resting state and pain-evoked functional connectivity. There is an altered glial activity. There is an altered structural integrity and connectivity of white matter. And there is an impaired descending inhibitory control at different centers of the brain. Or to say that at the level of basic science, it has been demonstrated changes in animal models of persistent nociception. And I want to quote verbatim Professor Cervero, who was a former director of our research center. He understood very well the fact that there is a huge gap between what happened to the animal and what happened to our patients. And unfortunately, he's not very positive when he says that sometimes the concept of central sensitization from a clinical point of view might be just an excuse in order to help us, to help our patients understand that we don't really know what's wrong with them. So it's an excuse to give comfort. And of course, we need to give comfort to our patients, but also we need to be effective. Therefore, this explanation has to be accompanied by some therapeutic changes, or at least some diagnostic changes, which I hope that I will be able to prove now. What to say is that there is a huge gap between the clinic and the lab. In our center, as you can see, a bird's eye picture of the hospital to the left, I would say that in less than 10 minutes, you can walk down Pine Avenue, and then you can go to the McIntyre building where some of the research centers are based. However, this distance it's a bit poetic, allow me to, but this distance is much farther in clinical science because it is much easier to prove this phenomenon in an anesthetized animal rather than in a talking person who has emotions and cognitions. So let's talk about clinical aspects of central sensitization. Can we measure it? Yes, in theory we can. And the measurement of central sensitization has been based on three aspects: the presence of hyperlogisia, some patient-reported outcomes, and also the presence of pain beyond the boundaries of the original injury. So let me talk about first QST. So QST is quantitative sensory testing, and it can be as complex or as easy as you want to do it. This is a human model of central sensitization after local injection of capsaicin. Capsaicin injected intradermally can cause an spontaneous pain that doesn't last very long. It's a burning pain. It's pure substance P, so it burns, it hurts. Following the injection, there is development of allodynia. And this allodynia, it's at the site of the injection, but also around the injection, in the surrounding skin area. It's what is called secondary allodynia, but it's usually short-lived. It doesn't last more than 2 hours tops. There is also development of an area of hyperalgesia that typically is farther from the area of injection. And this hyperalgesia occurs at the site of the administration, But also there is a development of secondary hyperlogisia that may last 6 to 24 hours. This central hyperlogisia is probably one of the features of central sensitization in this model of central sensitization in humans. The fact that we cannot cause chronic pain in humans because this would be ethically unacceptable, it prevents the fact that we cannot do proper research. QST is a matter of assessing before and after the sensation and the pain sensation after applying certain stimuli. Temporal summation is probably one of the easiest features that they can be assessed in the clinic, and even with simple tools that we might have in the clinic. Temporal summation is defined as increased response to discrete painful stimuli. So in a patient without pain in blue, you can see how there is a temporal summation that is, although you can see that there is a tendency to increase the response, it's not very meaningful. In fact, typically it's not even significant. But in a patient with pain, repeated application of painful stimuli triggers exaggerated responses to that stimulus. This is clearly known as hyperlogisia. There is another feature of QST that it's in our domain in pediatric pain, for example, is a key test done for every single of the kids seen at the pediatric clinic, and our friend at the research unit, Dr. Martel, is an expert in that, for example, where we can try to identify how effective is the noxious inhibitory control by applying first a pain using a thermote. On the top right of the image, you can see a porcelain thermote that it can be, the temperature of that device can be increased up to 50 degrees, causing a certain amount of pain. But interestingly, that pain, when repeated the stimulus, is less severe, because another area of the body, like for example in this lady volunteer, she's volunteered to put her right foot into a bucket of ice water at 4 degrees, which is also painful. The application of this second pain inhibits the first one, and in fact there is a certain degree of inhibition that it can be measured, and it can be assessed whether the central inhibition or the sending inhibition can be measured and whether it's intact or not. It is known that in certain disorders, like certain chronic diseases like irritable bowel syndrome, fibromyalgia, chronic fatigue, depression, and even if in patients on chronic opioid therapy, this descending inhibition control measured with the conditioned pain modulation test is impaired. In terms of patient outcomes measurement, there is one test that has been validated in different languages, and it's called the Central Sensitization Inventory. It consists of 25 questions that it can be answered from never to always, and there are 5 different answers with 1, 2, 3, or 4 points. So the maximum score of this test would be 100. And then patients, they have to answer whether they have these symptoms or not. This presentation is recorded, so you have access to this presentation later on, and then you can look at this questionnaire in detail later. When the patient rates this questionnaire with a cutoff value of 40, and the patient presents with one of these 10 pain symptoms, a diagnosis of central sensitization can be made. The matter of the cutoff is very interesting because the cutoff has been changed in different pathologies. So the cutoff, the authors, they suggested that there is a cutoff of 40, but in other papers, this cutoff has been lowered, depending on whether they could find other features of central sensitization. It's also interesting because the authors, they suggest a certain degree of a severity degree. So not just a cutoff of 40, but also when patients present a value of 60 and beyond, it is considered that central sensitization is severe. However, 25 questions answer is a very long one if you put with the many other questionnaires that we use in clinics. Therefore, there is another research done with a shorter form of the central sensitization, which is only 9 items. And of these 9 items, of a maximum score of 36, if the patient scores more than 20, also the diagnosis of central sensitization can be done in a valid way. That is interesting because it allows us to maybe not burden our patients too much with questions. Now, is there any link between what the patient says and what the researcher or the clinical, the clinician finds in the clinic? Actually, yes. In this study, they took patients with pain and some volunteers without pain. And among the patients with pain, they found that there were some, they were presenting with a low central sensitization inventory. They put the threshold at 33 points. And those with a high CSI, they were presenting with a statistical correlation with altered pressure pain thresholds and altered hot and cold pain thresholds, and also the presence of temporal summation. And that was not the case of patients with a low CSI, or obviously with patients who were asymptomatic in the control group. The last feature of central sensitization that is worthy mention is the fact that the patients, they describe their pain beyond the anatomical area that is originally causing the pain. So there is research done in particular in peripheral osteoarthritis with knees and hips. With patients with knees, they found a difference between female and male. And in those patients with a higher CSI scores, it was found that there was a wider representation of the pain that also came accompanied with lower pain thresholds at the knee, which is obvious because you cannot really tell if a patient has central or peripheral sensitization when you test the knee. But also interestingly, they found that there was a decreased pain threshold at the epicondyle. So this is a clear feature of a central lack of inhibition, because pain at the epicondyle, it doesn't make any sense when what you're having is knee osteoarthritis. The same was true for hip osteoarthritis. Interestingly, these authors, they were testing the link between the pain drawings and other outcomes, but they were not using the central sensitization index. Instead, they were using the widespread pain index, which is also the one that it was used previously at the last diagnostic tool for fibromyalgia, for example. Also, it was found also that patients with central sensitization, they had lower pressure pain thresholds at the thenar eminence, which is the hand. So that also shows that there is something wrong with the nociceptive pathway, because there is pain in areas that it should not be pain. The clinical picture of a patient with central sensitization includes local pain, of course, pain spreading to other areas. There is increased pain sensitivity at the local, but also in remote areas. There is sensitivity to light, sensitivity to others. Therefore, I would say that there is decreased inhibition, and the whole nervous system is hypersensitive. And there are other factors, since we know that pain affects some central centers of our brain that also they are linked to emotions. For example, stress is an aggravating factor, along with difficulty with concentration, memory problems, and sleep problems. All these in the context of a patient with severe symptoms but the anatomical changes that can be found in the imaging test, they are not correlated. Something that we're good at explaining to our patients. We know that the MRI of a patient with headache typically is normal, and patients, they kind of understand, but patients, they don't understand when we tell them that the MRI of the spine is not that bad, other than this protrusion and that slight or mild osteoarthritis, but the pain is very bad. So this is the classical picture of central sensitization. And why is that relevant? First of all, it's relevant to patients that we don't see at the pain clinic, but eventually they might end up being our patients. Patients who are going to undergo surgery, and it is known that patients with central sensitization, if they go through a painful stimulus, can be surgery or can be an accident, there is a higher chance to develop chronic pain. There is a chance to develop persistent postoperative or post-traumatic pain. So it would be great if anesthesiologists who are interested in pain, but also practicing anesthesia, could implement this tool in their pre-anesthetic evaluation in order to identify these patients who might be at higher risk to develop persistent pain. In the clinic, our patients in the clinic, typically they don't develop central sensitization. They come with it already developed. And it is known that the presence of central sensitization predicts poorer response to medical treatment. Also, to make things a bit more challenging, it is known that the presence of central sensitization is relevant because it indicates multidisciplinary care. And pain clinics without multidisciplinary care might not be well equipped to treat this pain. So in order to plan the multidisciplinary treatment, of course, when you work and at a multidisciplinary pain treatment unit, you have to offer medical, psychological, physical, and nursing interventions. And mind you that I put education at each of the 4 levels, because I believe that in this particular case, it is crucial that the patient understands, maybe to comfort or not, maybe Professor Severo wouldn't be in agreement with me, but I understand that patient must be in the same page when understanding that this is not a normal pain, yet this is something that it can be reverted. At least in experimental studies, it can be reverted, and also in some clinical studies, some changes that have been reverted after successful treatment. So I'm going to go over the different options of these 4 options, and I'm going to give you some examples. First, and I believe that the most important, is education. So we need to explain patients what is central sensitization, and it is in the times of COVID, it's harder to put them together and give them the proper explanation, but we must find a way for patients with central sensitization to understand that their nervous system is wrong, and that can be reverted, but it needs to be treated. And possibly the treatment is not the medically-oriented treatment that we all have in mind when we have pain, which is analgesics. We need to explain to patients the psychosocial model of pain, and we need to explain to patients that we need to change the locus of control in order to make them participant in the treatment plan. It's interesting, but one of the questions when you are treating a patient with central sensitization is, can you treat the periphery? I'm going to answer that a bit later. However, in this review, authors, they suggest that there are 2 types of central sensitization patients. Those with an increased top-down facilitation or a decreased inhibition, and those where the problem is more bottom-up. So when the problem is bottom-up, it is possible that patients, they might resolve the problem by treating the periphery. It is possible that these patients, they have less psychological comorbidity, it is possible that these patients, they present with less hyperlogisia in non-painful to non-painful stimuli. And these patients, they might present with less comorbid pain syndromes like fibromyalgia, chronic fatigue, IBS, migraines, and so on. I ask myself, if there is a pure bottom-up model, it might be hard to prove that this is central sensitization by the factors that I'm just presenting. Anyway, probably we can always say that a patient presenting with early signs of central sensitization, luckily, will be presenting with mostly bottom-up factors, but when the central sensitization is fully established, we might expect features of top-down facilitation, which might represent that treating the periphery is no longer effective, that that patients, they have had this pain for a very long time. We know, unfortunately, that females are more prone to develop this problem. These are patients, but also families in pain, patients and their parents with pain problems, carrying a high psychological comorbidity, and presenting with increased hypersensitivity to pain and other pain syndromes overlapping. Treating from a medical point of view, of course, we need to think of drugs. We need to think of anything that might inhibit at the periphery, if that is possible. Also, we need to decrease the nerve conduction at the level of the first synapses. Therefore, we can work with anticonvulsants, but also other drugs that, for example, an NMDA receptor antagonist that potentially might decrease the so-called wind-up. I believe that with a patient with a well-established central sensitization, we need to work with higher levels. So therefore, we need to increase central inhibition. Therefore, antidepressants probably is the most useful drug. Cannabinoids, they haven't been properly established. However, some of the actions of cannabinoids, they go along with some of the changes that I presented at the beginning of the talk. The presence of opioids in that list, it makes me feel a bit tense. The fact that opioids in the long term, they might cause increased sensitivity in the form of opioid-induced hyperalgesia might call for precaution. Therefore, probably tramadol is the best opioid in this case. Similar to what are the recommendations for the treatment of fibromyalgia, where opioids are not indicated, and tramadol is probably the only opioid that it's indicated. In fact, if I may, I would like to add another type of opioid, which would be opioid antagonist. If it's true that there are glial changes facilitating the development and the persistence of central sensitization, it is possible that low-dose naltrexone might be useful for these patients. Of course, this is a very complex pathology that it cannot be resolved with a single treatment. That's why we need the help of our colleagues at the pain center, including our psychologists. And this is, I will not pretend to be an expert in the field of psychology and pain. So this is a list of possible options. The way that I see is that patients, they need to be part of the treatment. They need to build effective and participative coping strategies. They need to understand that rest is their enemy, but proactive attitudes, they increase the chances to get better. From a point of view of physiotherapy or physical therapy, I find it interesting to identify whether the patient has aversive behaviors or whether it has motor behaviors that potentially might be harmful for the patient. So the patient needs to know how to move, what to do, and what to avoid. In particular, kinesiophobia is something that we see in our pain patients very often. Physical deconditioning needs to be treated. And our physiotherapists, they cannot probably apply very particular treatments to the periphery because these patients, their problem is not peripheral anymore. It's what we call supratentorial sometimes. So, but still the action of the treatment of a physical therapist is crucial in this patient. we wouldn't be good doctors without good nurses, and they can help us with not just with clinical reassurance. This is important that the patients, they understand that that pain is real and we need to treat it, and they can help us by doing the co-management of pharmacological treatments. But also, I would say that the new use of ketamine for certain pain syndromes might become a bit more fashionable if we could demonstrate that central sensitization might respond to ketamine infusion. And in particular, now we don't really know how to use ketamine. Probably the best protocol for ketamine infusions are multi-day infusions, and which is not very easy, at least not in our clinic for lack of resources. But I really hope that one day we will have a very good ketamine protocol that potentially will help our patients. I personally remember very well the case of a lady who presented with a whiplash. And after doing all my best with peripheral blocks, I asked one of my colleagues in clinic if there could be anything else that I could do or that I was maybe missing. I remember that he wrote in his note that this patient was presenting with central sensitization. I don't know how he found that. I don't know what were the signs and symptoms that he found to justify this, but she's much better now that she's receiving ketamine treatment. And so probably I think that from a pharmacological point of view, we need to dust up ketamine for our pain patients. And for the interventionists in the audience, we can inject these patients. However, my experience with a large cohort of fibromyalgia patients when I was working in Barcelona told me that these patients, they have a very hard time when you inject them because they have hyperlogisia. And also the type of response that they're gonna present is not gonna be too encouraging. So the injection hurts more than it should, and the effect is less predictable. I wanna present 3 articles that I find interesting. One is trigger point injections in patients with or without fibromyalgia. In those patients without fibromyalgia, trigger point injections, it works better. That doesn't mean that trigger point injections is contraindicated in patients with fibromyalgia. It's just to say that it might work less. In patients with low back pain and central sensitization, or fibromyalgia in this case, the response is considered. They found that these patients, they were having more procedural pain, but also the response was, and when they say aberrant, they meant that they were not presenting with the consistent analgesic response to a medial branch block. And the last one, it was, this is a present to Dr. Scheer, because he keeps saying that if the pain is central, you can still treat the periphery. And this is something that it took me a long time to accept until I found this. And actually, this is something that now I have to say that he's right. These are 10 patients with central pain, central neuropathic pain, receiving peripheral blocks. Of these 10, 8, they responded positively. They got pain relief, even if the disease was at the central level. So I don't understand why, but certainly it is not, I would say it is not bad practice to concentrate on the pain area, even if the source of the pain is no longer at the periphery, but more at the central area. I would say that if you identify your patient who is more on the bottom-up pattern, as you can see on the right table, I would say that it is possible that a peripheral injection might be helpful. Some final thoughts about this. When you're a researcher, central sensitization, it is clear, it's evident, and it is easy to make it objective. It's a physiological phenomenon that can be observed in animal models of nociception. It can be reversed by reversing the pathological changes that you have observed. And the greatest advantage is that when you do basic research, nociception and not pain can be objectively assessed and compared between before and after or between different models. The problem is that when you start wearing the stethoscope, then you see that sometimes peripheral injuries can can end up causing chronic widespread conditions or central sensitization. We know sometimes that the treatment of the periphery might or might not reverse the secondary central consequences. And the fact of not knowing makes the choice very hard, and for the patient makes the choice very frustrating because you don't really know what's going to happen to the patient when you treat the periphery. The problem, of course, but that's the beauty of our job, is that chronic pain is subjective and is subjected to physical and emotional variables, not like in experimental animals. Therefore, it's not that easily assessed and compared. So some thoughts for the future of my patients with central sensitization. What I would like to do is, I'm going to start paying more attention to the pain distribution and see whether the pain is in areas that it cannot be justified by the initial injury. I think that we should, the same way that we can test a sensation with a brush or with a prick, we should start using other tests in order to prove that there is hyperlogisia. So a dolorimeter is something that is cheap, that it can be assessed in the clinic very easily. The central sensitization inventory, it is burdensome, but it might help at least identifying the patients with severe central sensitization. So I think that this is something that we could integrate into our practice. And we keep telling patients that sometimes the lack of response is also a good response, because at least we know what it should not be repeated, and at least we know where the pain is not coming from. So in certain patients, when we treat the periphery, if we see that there is a lack of progress, we might want to integrate the possibility of central sensitization into our diagnosis. And this is my final slide. I will stop quoting central sensitization when I can no longer explain my patient's pain. Before I say central sensitization, next time, I pledge to provide with symptoms and signs that they explain. I hope that after this presentation, you understand better the pathophysiology, that you can integrate the diagnosis into your routine clinics, that you can engage patients into their treatments by explaining why central sensitization is, and that you can somehow identify the best therapeutic options for these patients. I believe that if we build a diagnostic toolbox to identify these, at least the severe cases, I think that we will be able to identify patients who should get specific treatments and not. I think that we need to design educational tools for these patients, and mostly we need to better educate ourselves in order to communicate with our colleagues in the pain treatment, in order to put patients in the right box. And central sensitization is one of those boxes. I have complete my presentation. I hope that you found it useful, and I stand by for your questions. Thank you.